Okay, hello everyone. I hope y'all could hear me. I have the honor and the pleasure to welcome everyone to the uh, Lawrence and Evelyn Wing Family Lectureship. This is the sixth time we're offering this. This is part of the celebration for the Asian Pacific Heritage Months. And we have a wonderful speaker today as well. But before I introduce our honor speaker today, let me introduce you about the Wing Lectureship. Oops. Why isn't it moving? Okay, here we go. All right, so the Wing Family Lectureship is endowed by the Wing family and their donors to honor Larry and Evelyn Wing, who I had the pleasure of knowing for many years. Larry was a board of trustee at Joslin and a patient as well here, and who really inspired me to work in the Asian American area especially with diabetes. And this, let me introduce you to the Wing family, Linda Wing, Dr. Lauren Wing, the daughters, and Lever Wing, their son. In a few minutes, I'll have Lever say a few words, Mr. Wing say a few words. But right now, I just want to mention that this is all the wonderful donor who have enabled us to have this lectureship. This is the picture of the family, the 5 families that initially founded the Asian American Diabetes Initiative back in 2000, and as well as the staff of the AADI now, who are helping us to do all the work, outreach work, the Asian Clinic, education materials, and many other activities of the AADI team. Now, before I go introduce you about the speakers from the past and the present, let me ask Mr. Lever Wing to say a few words at this time. Mr. Wing, would you like to say a few words?
Thank you, Dr. King. Thanks so much for this opportunity. Good morning, good afternoon, actually, everybody. My name's Leverett Wing. I am one of the 3 children of Lawrence and Evelyn Wing. And on behalf of our family, wanted to thank all of you for joining us today. It's a beautiful Monday afternoon, and you are all here sitting in front of a computer or a tablet or phone and listening to this. And we are grateful for your time. We're very grateful to Dr. King and Joslin for providing this opportunity for all of us. Dr. King and Joslin, the leadership that they have displayed, particularly with the Asian American community, is second to none, and we are incredibly grateful to them. Also our donors, who were listed a little bit earlier, and Dr. Kanaya, who continues the incredible tradition of the lecturers who have come through this Lawrence and Evelyn Wing lectureship, nationally and world renowned. We are grateful for you for being here, Dr. Kanaya. Before I turn it back over to Dr. King, one of the people I wanted to acknowledge. We lost a dear friend of the Asian American Diabetes Initiative yesterday or the day before, in Jasper White. He was the owner and founder of Summer Shack, and he was actually one of the core foundational pieces of the Taste of Ginger, which was for many, many years, and actually still is, one of the primary fundraising tools for AADI. And without Jasper and the gravitas and cachet that he brought to the table, in our first few years, especially, and some of his friends in the culinary world, AADI and Taste of Ginger would not have been nearly the success that it turned out to be. And so I don't think the impact that Jasper had can ever be overstated, and we will miss him dearly. But thank you all again for being here, and thank you again, Dr. Kanaya, and thank you to Joslin for this opportunity.
So thank you, Lever, for that thoughts. And I also want to add my really sadness to the passing of Jasper, who have come to know for many years, have become very good friends with Diana, myself over the last few years. And okay, so let me move ahead. That this is a wonderful endowed lectureship here, where we bring in really world-renowned researchers and in the area of studying Asian American health, with particular emphasis on diabetes. This is the sixth one. If you notice that not all the speakers are incredible in their achievements. And for the sixth lecture, we have the really privilege to have Dr. Alka Kanaya, who is a professor of medicine, epidemiology, and biostatistics at UC San Francisco. And this is a short list of her very high volume curriculum vitae. She received a medical training from University of California, San Francisco, and training in medicine, and achieved resident and fellowship at the same institution, and as well as now professor of medicine, epidemiology, and biostatistics, UC San Francisco, and you as well. I guess Alka, you really like San Francisco, and Dr. Alka Kanaya focused her research on type 2 diabetes and cardiovascular disease epidemiology in order to identify and understand the causes of this really prevalent disease in Asian Americans and its disparity. She is the lead investigator for the mediator of atherosclerosis in South Asian living in America, or the really well-known Marcella study. And last year she received the most prestigious award from the American Diabetes Association, Kelly West Award for outstanding achievement in epidemiology. And since she's not here, we are presenting her the recognition certificate online, and hopefully next year we'll revert back to in person. And so now I'm asked Dr. Kanaya to present her lecture, Cardiometabolic Health of South Asian Americans. So I'm going to stop share. Oh, I stopped already.
Thank you so much, Dr. King. And it's my honor and privilege to give this lecture. And I thank the Wing family for making this possible. And I wish I was there with you in person, but hopefully this will do. And I want to give you a tour about what we've been learning about the cardiometabolic health of South Asian Americans today. So diabetes affects, more than 500 million people globally. And about 80% of those with diabetes are living in low and middle income countries. And South Asia is currently at the epicenter of diabetes, with really fast growth in this very populous region. But what we know about South Asia, also is important to understand in the context of the South Asian diaspora, where people from South Asia have migrated to. And you can see the earlier waves of migration were southward towards South Africa and other countries in Africa and Southern America. And more recent waves were to the UK, and now in the 1960s onwards to the Canada and United States, and currently more and more to Australia and New Zealand. And so the current South Asian diaspora encompasses about 1.9 billion people, or 23% of the global population. But what we learned about diabetes being a real problem in South Asia didn't come from studies from India or the South Asian region. They actually came from migrant studies, from immigrants that were found to have really high prevalence of diabetes, whether in the UK or in other countries in Southern Africa or Singapore and Malaysia. And so this phenomenon has really unfolded over the past 4 to 5 decades. And what do we know about South Asians in the United States? Well, as you all know and are keenly aware, Asian Americans have been aggregated together in one race group that includes people with origins from 23 different Asian countries. And the growth of the Asian American population has been quite high, at least 40% change from census 2010 to 2020. And currently, the 6 largest Asian subgroups in the United States are Chinese Americans at 5.5 million, Asian Indians at almost 5 million, and then Filipinos, Vietnamese, Korean, and Japanese. So these groups now account for 7% of the total US population. And as you all have heard, starting now, the OSMB rules have asked that a lot of the data be disaggregated into at least these 6 main Asian subgroups, and with more granularity for all of these other 23 countries of origin. So what we know about diabetes doesn't come from large national data sets, because again, Asian groups are aggregated together. So this is the National Health and Nutrition Examination Survey that started to oversample Asians in 2011, and we put together 3 waves of NHANES data and looked at the prevalence of total diabetes. And as you can see, the non-Hispanic whites had about 12%, Blacks about 20%, Hispanics 22%, and Asians were 19%. And we worked closely with CDC colleagues to disaggregate the Asian data at least into 3 geographic regions. There weren't enough people that were sampled in each of the different country of origin groups to be able to further disaggregate, but we were able to disaggregate into East Asian representing Chinese, Japanese, Korean, South Asian representing Indian, Pakistani, Bangladeshi, and Southeast Asian. And you can see there's a great heterogeneity among these 3 groups, again, showing that there is this phenomenon of a lot of prevalent diabetes in South Asians as well as Southeast Asian groups and East Asians compared to that in non-Hispanic whites of the United States. What we've also found looking at data sets of health systems data, this is from Kaiser, Northern California, where this group looked at the 10-year incidence of heart disease by group, again, trying to disaggregate South Asians from East Asians and other Asians from other groups. And you can see that both for men in orange and women in gray and the total number in blue, South Asians not only have been found to have high rates of diabetes, but there's also this high prevalence of cardiovascular disease, or this is heart disease, myocardial infarction, in both men and women compared to all other groups. And the sad part is that while mortality from ischemic heart disease seems to be falling for most groups, this shows you mortality rates in men on the left, women on the right, and these curves go from 2003 to 2017. The black line is in whites. You can see that people die less frequently of ischemic heart disease now. But if you look at the green curve, that's the Asian Indians, the curves are going in the wrong direction. They're going up. with men having higher mortality than they did earlier, and women actually having higher mortality as well. So there is a problem here, not only diabetes, but cardiovascular disease and mortality. And so that's kind of the background for why we decided we needed more data in South Asian Americans and launched the MASALA study that stands for Mediators of Atherosclerosis in South Asians Living in America. And this was funded by a R01 grant from the National Health, Heart and Lung and Blood Institute at NIH. We included people who were between age 40 and 84 years. They had to have no existing cardiovascular disease to be in the cohort. So already you can see that if you've made it to 84 without any cardiovascular disease, this represents a slightly healthier subpopulation of all South Asian Americans. We had enough funding to do the recruitment at 2 sites, at my site, UC San Francisco, and Northwestern University in Chicago. And to date is the only longitudinal cohort of US South Asians. And we purposefully made this study, MASALA, to be parallel in methods to the multi-ethnic study of atherosclerosis, which is a study that has been going on since the year 2000 and includes 4 different race ethnic groups. And I'm going to be using this color scheme throughout my talk to show you some comparison data between the South Asians in orange, whites in blue, Black Americans in purple, Hispanic Americans in green, and Chinese Americans shown in red. So here's what we've accomplished in one quick view for the past 12, 13 years in MASALA. I want to shout out to my other 2 co-principal investigators, Dr. Nami Kandula, she's at Northwestern, and more recently, Dr. Nadia Islam, who's at NYU. So we started MASALA in 2010, brought people in 906 to do a 6-hour clinical exam. We brought back 83% of the cohort for a second exam, and we got a little philanthropic funding to expand the cohort with another 258 participants. And currently we are finishing up our exam 3 of the surviving cohort, looking at cardiovascular function. And we got a new grant from NIMHD to double the size of our cohort and recruit Bangladeshi and Pakistani South Asian subgroups that weren't well represented in our original cohort. So by the end of this year, our cohort size will be almost 2,300 people. And the data that I show you for this talk is really coming from the original cohort of 1,164 people, the data that have been already analyzed and published. So who are the people in this study? 98% of our participants are immigrants to the United States. This is true based on census data for this age group of 40 to 84. Only 2% were born in the US, 83% were born in India, and 6% in Pakistan, and 1 to 2% in the other South Asian countries. And that's why we are so fortunate to now be expanding the cohort by adding more people who were born in Pakistan and Bangladesh, the 2 other largest South Asian subgroups in the United States. We've recently done whole genome sequencing of the cohort, and we've looked at genetic ancestry. And what this graph shows you is 2 principal components, clustering methods, looking at all these traits that determine our genetic ancestry. And what I want to show you is that most people fall on one cline, and that's the North Indians, as well as Pakistanis and Nepalis and Bhutanese and Bangladeshis are in that green area, and the South Indians are in the blue area, including Sri Lankans that are here as well. And then there's this one other cluster of people who come from this region of India called Gujarat, a Western state. And so this cohort does represent people with genetic ancestry from this region of the world. So who are people in this study again? About half men, half women, half were recruited in Chicago, half from the San Francisco Bay Area, and their mean age was 57. The mean number of years that they've lived in the United States is about 28, so about half of their life. was in the United States. And then you can see some are fairly recent immigrants, and some have been in the US for more than 80% of their life, so a normal distribution. This is a highly educated group. And again, this is because of the immigration laws, as you all may be aware of. In 1965, the immigration rules only allowed immigrants to come to the United States if they were coming for higher education or had professional work backgrounds. And so this group of primarily Asian Indians in the study, 86% had a bachelor's degree or higher. And you can see the family income is relatively high as a result. So if anything, what I've told you so far about Masala to keep in mind is they couldn't have cardiovascular disease if they were to join this study. So it represents people who've made it to age 40 to 84 without cardiovascular disease. And this is a relatively highly educated and high SES group. So these are protective factors. And so you would think that whatever data I show you should be like the rosiest picture of South Asian Americans. So in the next 30 minutes, I'm going to kind of go through what we've learned about diabetes, body composition, atherosclerosis, and other risk factors for heart disease, and what are modifiable risk factors. So the prevalence of diabetes in Masala was quite high, and that's shown in red. About 26% of the cohort had diabetes based on fasting glucose levels or 2-hour glucose tolerance levels. And about a third had pre-diabetes. But you can see there's a gender difference with 30% of men having diabetes and 21% of women. And how does that compare to the 4 groups in MESA? So I'm using that same color scheme I mentioned for the 4 groups in MESA, and you can see without any adjustment for age or any other risk factor, the South Asians had higher prevalence of diabetes in the 4 groups. And you'll ask me, well, why did that go from 26 to 21? That's because MESA did not do oral glucose tolerance tests. They only had fasting glucose levels. So we removed the 5% of people who were diagnosed based on oral glucose tolerance testing for apples to apples comparison here. And then when we fully adjusted our models, and this is adjustment for all metabolic risk factors, blood pressure, BMI, waist, as well as socioeconomic factors, income, education, lifestyle factors, diet, exercise, we saw even a greater difference in diabetes prevalence with South Asian at 27%, 7% in whites, 13% Chinese, 15% Blacks, and 10% in Hispanic Americans. So there is this definite difference in diabetes prevalence, and the question is why? So we looked at people without diabetes to look at, well, what's happening with their insulin resistance levels and their beta cell function. So this is using surrogate measures of insulin resistance with a HOMA-IR calculation. South Asians shown in orange, all the other groups in MESA are shown in dotted black lines. And what you can see is South Asians had a higher prevalence of insulin resistance compared to all other groups, at least until age 65. And then there's much more of a mixed picture down here, probably because there's very sparse data here as well. But in terms of beta cell function, there is much lower HOMA beta levels among the South Asians compared to the 4 groups in MESA. Now, again, these are people without diabetes, not on any diabetic medications, and we're seeing both this low beta cell function and also high insulin resistance. And most of the studies from all those diaspora countries that have found that South Asians have more diabetes have really focused in on insulin resistance as being the driving factor here. But I think that there may be more of some primary defects in beta cell function. And this was true across the BMI spectrum, that there's higher insulin resistance based for the South Asians up to the BMI of 30. There actually are very few South Asians above BMI of 30 to have any accurate data there. And also low beta cell function across the entire BMI and waist spectrum. So what have we learned about in terms of people who have diabetes and the subtypes of type 2 diabetes. So this was a nice paper led by Michael Banks, and he put together the people with diabetes, about 1,300 people in Mesa and Masala, and this is the exact number of participants from the two studies who had type 2 diabetes. And he looked at clinical variables, age, BMI, hemoglobin A1C, HOMA-IR and HOMA-beta, and we compared the different subtypes and looked at different long-term outcomes, complications of diabetes by subtype. And these are the 5 main subtypes that he found. The most common one across all of the groups was this older age at onset. About 44% had old age at onset type 2 diabetes. A quarter had severe hyperglycemia. This is the insulin deficient type of diabetes where the HOMA-beta levels were quite low and hemoglobin A1C was very high and BMI was quite low in this group. The third group is severe obesity. This was the very insulin resistant group with high HOMA insulin resistance and high BMIs. And then the smaller cluster was an insulin-using type 2 diabetes with completely exhausted pancreatic beta cell function and needing insulin. And then there was a very few people with young age at onset type 2 diabetes. And how does this differ in terms of the 5 different groups of people by genetic ancestral backgrounds? And what I want to focus in on is the South Asian group. The most common subtype of type 2 diabetes was not the older age. That was only 29%. The most common one was the severe hyperglycemia or the insulin deficient subtype, almost 40%, much higher than in Chinese, Latinos, Blacks, and whites. And so I just want to point out how different the distribution of the subtypes is in the South Asians compared to the Chinese side by side. And aggregating data for East Asians and South Asians is not very helpful to be able to look at this nuanced difference. The Chinese Americans in Mesa, the most common subtype was the older age at onset subtype, 67%, and then followed by the insulin deficient subtype that was most common in the South Asians. The South Asians, the second most common subtype was the older age, and then the insulin resistant subtype. Why does it matter? Why should we care? Well, we are all trying to do more individualized, precision-based medicine, right? And what we found in terms of longitudinal outcomes is people in this severe hyperglycemia, the most prominent subtype in South Asians, had the highest incidence of developing coronary atherosclerosis or calcium plaques in their coronary arteries. And this is a group that if you were to see a patient in this subtype, you should consider using the newer agents that have been proven to lower cardiovascular disease risk, like the SGLT2 inhibitors, GLP-1 agonists, and you wouldn't necessarily reach for metformin first. You would go to these better proven medications first. The older age at onset group had very few adverse outcomes. This is the least aggressive form of type 2 diabetes, may need less medications or less tight glycemic control. And then the insulin resistant subtype of type 2 diabetes had no higher incidence of chronic kidney disease or atherosclerosis. So this subtype may be best managed with weight loss, metformin, TZDs, potentially some of the newer agents that do promote weight loss as well. And what have we learned from looking at all of the different studies from around the world that have looked at diabetes type 2 subtypes? And this is a nice paper done by Jitin Varghese, where he looked at Asian studies on the left panel here, and I've shown you East Asians at the top, South Asians, mostly from India, at the bottom, and then these are non-Asian populations. And the severe insulin deficient subtype that was very common in South Asians, you can see even in the Indian studies was quite common, is less common in the non-Asian studies that have been done from Scandinavian countries as well as Southern European countries. And it was kind of mixed picture in the East Asians, some showing lower, some showing higher, but not as high as what we see in the South Asians. This is that severe insulin resistance subtype. The obese subtype was intermediate here and was somewhat lower in the non-Asian groups as well. And then here's that oldest age at onset, that maturity onset type 2 diabetes. And we're seeing that this was fairly common across all groups and most common in the non-Asian subtype. So there are differences in the distribution of these 4 main subtypes across different groups. So I'm going to go on and talk a little bit about our body composition data in Masala, but first let's talk about the surrogate measure of body mass index. And you all know that BMI is an imperfect surrogate measure. And what we've done is, as you all know, we have found that BMI of 23 or greater has been associated with a higher prevalence of diabetes in Asians, and the American Diabetes Association, the U.S. Preventative Services Task Forces have adopted new guidelines saying Asian Americans should be screened at a BMI of 23 or greater. And so we use those criteria to look at the prevalence of normal weight or overweight and obese in Masala and Mesa. And here I'm showing you in orange, the South Asians had about 25% in the normal weight category using that BMI less than 23. East Asians, so the Chinese, had about 40% in the normal weight BMI classification. Overweight, almost all of the groups were about 40 to 50%. And obese, the East Asians, the Chinese, had the lowest prevalence of obese. South Asians were right in the middle at about 25%. But what can we learn by looking at the people in that normal weight classification? Because that's where diabetes screening is not recommended, right? Less than 23 for Asians or less than 25 for other groups. And so we wanted to examine this group carefully. And what this is showing you in the red circles are people with any metabolic abnormalities based on the metabolic syndrome definition of high glucose, high blood pressure, high triglycerides, or low HDL. So people with 2 or more metabolic abnormalities are shown here. And if for the normal weight group, South Asians had almost 45% of people who had normal weight but metabolic abnormalities. And you can see that each of the groups, even whites, about 20% of whites had metabolic abnormalities in normal weight, and almost 30% Chinese, 30% African Americans, and 35% Hispanic. So every group had people in this normal weight criteria who are overlooked in terms of clinical practice. We don't check glucose, fasting glucose or hemoglobin A1C in these people. And so what BMI can be considered relatively normal if we use the surrogate measure of BMI clinically. And what we found was, for a South Asian American, having a BMI of 19.6 was roughly equivalent to a white American's BMI of 25 in terms of the number of metabolic abnormalities. And the other groups were somewhere between 20 and 23. And so bottom line is, a normal BMI does not mean you have low risk of metabolic risk factors for any group. But especially for the South Asian Americans, the BMI is quite a useless surrogate measure. So what should we be using then? In a research study, we were able to do fancier radiographic tests to look at ectopic fat. And what we were able to measure by CT scan was fat in the muscles, fat in the liver, fat around the visceral abdominal organs, and fat around the heart. And we did the same CT protocol and reading centers as MESA in these comparisons. And what we found was that South Asians store fat in all of the wrong areas, much more than the MESA groups. So this is looking at hepatic attenuation. This is an inverse measure. So the lower the attenuation, the more fat there is in the liver, and there's significant differences here with the South Asian having the most fatty liver compared to the other 4 groups in MESA. Visceral fat was quite high in South Asians, about equal to white Americans, but much higher than in the other three groups in MESA. Intermuscular fat, fat inside the muscle, was much higher in South Asian Americans compared to the four groups in MESA. And total lean mass, muscle mass, was the lowest in South Asians. So this is pointing to ectopic fat being a potential reason that there may be so much more type 2 diabetes in South Asians. And so we looked at this in terms of progression of glycemic status over 5 years of follow-up. And what we found was the South Asians are having a rapid transition from normal glucose tolerance, impaired fasting glucose, to both IFG and IGT. And the most rapid transition goes from IFG, IGT to diabetes, with an incidence of about 20 per 100. And being quite rapid compared to other groups in MESA. And when we looked at what predicts who goes on to have rapid glycemic progression, both visceral fat area and having fat in the liver were both associated with having the rapid glycemic progression and independent of each other. And again, this is an inverse variable, so this again shows higher fat in the liver was associated with more progression of the glucose status. We've recently been looking at metabolites to see if we can learn more about metabolites, because it's not reasonable to do CT scan measures to look for ectopic fat in the clinical setting. So what can we use to help us with this, the hidden ectopic fat depots? We know waist circumference is not a great measure as well. So we used our research data at looking at liver steatosis as well as visceral fat. And then we also did metabolomics. And Dr. Gadgil led this study where she found that there were 267 metabolites that really corresponded nicely to a liver score that had high degree of correlation with the measured, CT scan liver fat. And then she found 313 metabolites that were used to develop this visceral fat score. And what she found was, when we looked at who developed incident diabetes after 5 years of follow-up, and this is again a fully adjusted equation that we adjust for socioeconomic factors, energy intake, other dietary factors, as well as the CT measures, that these metabolite scores were better predictive of who develops diabetes by about an odds ratio of 2. The metabolite factors from visceral fat and liver fat were predictive of incident diabetes. So this is exciting to me, because I think that we see a future where these types of studies are being done in many cohorts, that we could actually be able to run specific panels of metabolites for patients to decide who is at highest risk of developing incident diabetes, independent of other risk factors, and who we should target with better interventions for prevention. So Dr. Venkat Narayan and I wrote a thought piece for Diabetology a few years ago, saying, trying to think about, well, what is the reason that we think South Asians are developing so much more diabetes? And we came down to thinking in 2 buckets, that there are evolutionarily determined factors, such as poor beta cell function, that impair insulin secretion, but also low lean muscle mass, from some really nicely done anthropological studies showing that this may be an evolutionary phenomenon in South Asians, where there's low lean muscle mass that can lead to impaired insulin action. And of course, the ectopic fat deposition, which is more of a response to lifestyle, can lead to insulin resistance and susceptibility to type 2 diabetes. I'm going to show you just a few other data about cardiometabolic risk factors that you may be interested in. When we look at just the usual lipid panel, there's not a whole lot of difference in the South Asians shown in the first column compared to the 4 groups in MESA. This is using people taking out anyone who is on statins, niacin, any other cholesterol altering medication. And there's really nothing super abnormal about the LDL or HDL or triglycerides for the South Asian group compared to the other groups. But there are big differences in lipoprotein little a. And this is just showing you the median value of LP little a for South Asians was 17, and it was lower for whites, Latinos, and Chinese at 13. And Black Americans had the highest LP little a level of 35. We know LP little a is genetically determined, and this has been seen in other studies that South Asians have relatively high LP little a levels. But what we found in Masala so far, looking at LP little a levels in our original cohort, is that LP little a was not associated with atherosclerosis measures of coronary artery calcium in the heart or carotid IMT thickness. So that's interesting because in some studies coming from other parts of the world, LP little a is independently associated with cardiovascular disease events, but we're not seeing it associated, at least with our measures of atherosclerosis. It's not associated with aortic valve calcification. And if anything, higher levels of LP little a are associated with more coronary artery calcium density over time, looking at 5 years of change. And dense plaques are protective. They don't rupture and cause heart attacks. And so higher LP little a was associated with density of plaques, which is a very interesting and not yet replicated finding that we hope that other groups will try to replicate in new data sets. So other metabolic comparisons, just to show you that South Asian phenotype in Masala was quite different in that there's lower levels of inflammatory factors in the Masala participants compared to all of the other groups in MESA. That's quite surprising given that there's higher ectopic fat levels. But the adipokines we measured, adiponectin and resistant, are quite aberrant in the South Asians, much higher levels of resistant than all of the other 4 groups, and lower levels of the protective adiponectin compared to all of the other groups. So again, hinting to that there may be, differences in ectopic fat that are driving some of these hormonal differences, and that they may be helpful in prediction of future events. So I want to show you some of the coronary artery calcium data in Masala. And this is a cross-section through the heart, and software can measure the white coronary artery calcium plaques in the arteries. And we know that this is the process of atherosclerosis, lays down a calcified shell and causes a calcified plaque, and that's what we're measuring here. And then the plaques can become vulnerable, rupture, causing a thrombosis, a clot, and complete disruption of blood flow, which leads to a myocardial infarction. So we're measuring, further down in this process of atherosclerosis when we look at hardened plaque. And what we found for the men in Masala, shown on the left panel, and the women, South Asians are here shown in red. This green line is whites. Across the age group, men in Masala had a similar CAC burden compared to the white men in MESA, and higher than the Chinese, African American, and Latino men. And this is true even after age 60 to 80. You can really see that there's really no significant difference between the CAC levels between white men and South Asian men. For the women, there's a very different y-axis. Women have lower levels of CAC on average compared to men. And all these women had higher CAC with aging, but there was no significant difference between CAC for all 5 race ethnic groups in MESA and Masala. We did find that glucose did affect CAC differently for the groups. And over here, we're showing you serum glucose levels, and the South Asians in purple have the strongest slope across glucose levels from 130 to 330, that the amount of CAC is highest in the South Asians as glucose goes up. And here's hemoglobin A1C as well. And Chinese Americans were just second to the South Asians in terms of the impact of glycemia on CAC levels. So I want to turn now in the last few minutes to modifiable risk factors, because that's really where we're going with this observational study is, learning about how we can change the disease trajectory, how we can impact disease risk with future interventions. So we used a socioecological model in how we collected data over time in Masala. And I'm going to focus in on the interpersonal factors and the individual level factors that we've been studying. So let's start with the individual level factors. Now, diet is something very interesting and difficult to measure in South Asians because diet varies region to region, from north to south, India, completely different diets. So we used a food frequency questionnaire that was derived in Canada for the SHARE study by Sonia Anand's group. It had 164 items, and we combined these items. Dr. Gadgil led this analysis of dietary patterns, finding 3 major dietary patterns in Masala. One was high in animal protein, included these factors down here. One was a dietary pattern that was high in fried snacks, sweets, and high-fat dairy. And many of you may be aware of some of these if you eat at Indian restaurants. And then the last was fruits, vegetables, nuts, and legumes, more of a prudent diet. And these were all the major food groups represented in these 3 very different dietary patterns. And when she looked at what each was related to, found that people eating this high animal protein diet had higher levels of total and LDL cholesterol, higher weight and waist circumference, and more liver fat. People in this middle traditional South Asian diet had lower HDL cholesterol and more insulin resistance. And the ones in this last diet pattern had the lowest prevalence of hypertension and metabolic syndrome. She went on to look at the metabolites of these 3 dietary patterns, finding that they did seem to correlate strongly to metabolites as expected for people consuming these diets. And this is important because, as we all know, dietary data on FFQs is limited by recall bias and many other problems, but having metabolite data that can back up these findings is another way to show strength in terms of the causal relationships. One of the nice new papers that has come out of the Harvard School of Public Health with our collaborator, Dr. Shilpa Bhupatharaju, was looking at plant-based diets. And what she did was categorize people into the numbers of healthy plant-based foods versus less healthy plant-based foods. And looking at how people with a higher healthy plant-based food dietary index did. And what she found was people eating more of the healthy foods had lower odds of fatty liver, obesity, overweight, and less incidence of developing type 2 diabetes after 5 years of follow-up. People eating more of the less healthy, the unhealthy plant-based diet actually had no real significant risk factors. There was a hint towards higher incidence of diabetes that wasn't statistically significant. What have we learned about physical activity? So remember, I told you South Asians had the highest income and the highest education compared to the MESA groups, but they have the lowest exercise levels, unfortunately. So, low-hanging fruit in terms of modifiable risk factors. And we found that the exercise levels were even lower among those with diabetes in Masala compared to those without diabetes. There's definitely more minutes of sedentary behavior, and that sedentary behavior was associated with developing incident diabetes as well. And how can we do that? What can we do to change this so that people are getting, more effects of physical activity? So we have done some qualitative work in Masala, and we found that men tend to exercise more when they exercise with a non-spousal exercise partner. So go exercise with a friend or a buddy. Women, however, exercise more when they exercise with their spouse as their exercise partner. And when we asked men and women in, a qualitative research, how they actually what makes them change their behaviors, and really everyone said it's not their doctor, it's not their friend, it's not their spouse, it's their adult children who are the influencers. When the adult children says, Mom, you need to walk more, Mom, you need to eat more fresh fruits and vegetables, Dad, you need to do this, they listen to their adult children. And that just gives us insight into how we can impact change in older South Asian Americans. Lastly, I want to show you a few slides about our acculturation findings, because I think that this is really fascinating. So we collected 9 different items, different questions to come up with acculturation strategies. And there are 3 main acculturation strategies using clustering analysis that we found. One is a separation class. These are people who are extremely South Asian in their cultural beliefs and behaviors, and that's about 20% of our cohort. Half are in this integration or this bicultural class, both adopting some American beliefs and behaviors and retaining South Asian ones. And then there's only about a third in this assimilation class. That's most American in the beliefs and behaviors. The people in the separation class, there's more women here. They've lived in the US for fewer years. They have lower socioeconomic status, less exercise, but they also use tobacco and alcohol less. And they eat more of that that traditional South Asian diet. People in the assimilation class have lived in the US longer, about 32 years on average. They have higher socioeconomic status, more exercise. They use more tobacco and alcohol, and they eat that animal protein diet more commonly. So what did we find in terms of their risk profile? And this is just looking at these 3, acculturation classes. We found that the people in that most South Asian separation class had the worst profile in terms of BMI, waist, glucose intolerance and diabetes, hypertension and fatty liver. And compared to the assimilation class, the most American class had the lowest BMI, had the lowest diabetes, had the lowest hypertension. That's quite interesting because this is very different from what has been found in Japanese Americans, in Latino Americans. The more assimilated you are, the worse your risk factors, but it's very different for the South Asians. And then what happens when we look at change in risk factors over 5 years of follow-up? And here's a little bit more nuanced finding. The people in that very South Asian group had more change in fasting glucose. They had faster change in coronary artery calcium. But that assimilation group, the most American group, had more change in weight and waist circumference. And that middle group, that integration group, the bicultural group, had the best risk profile. So the ones adopting some American beliefs and behaviors and retaining some South Asian beliefs and behaviors. So that is quite interesting, and we hope to explore this more as our cohort ages. I do want to show you some of our newest data that is trying to disaggregate the South Asians that should not also be aggregated together. So as I mentioned, we've been enrolling Bangladeshi and Pakistani participants from Chicago and New York City to really be able to look across these 3 major subgroups. And here's some of our preliminary data from the first 900 people we've enrolled. Compared to the Indians, the diabetes comparison, diabetes shown in pink here, Pakistanis have a lot more diabetes, and Bangladeshis have the highest prevalence of all, almost 51% of Bangladeshis in our new cohort compared to 24% in Indians. How about hypertension? Similar pattern, with the Bangladeshis having a higher prevalence of hypertension compared to the Indians and the Pakistanis. So this is just unpublished new data. We will complete this new sub-cohort by the end of this year and start to produce more papers after that. So in conclusion, I've shown you some of the whirlwind findings of Masala, that South Asians do have a higher prevalence of type 2 diabetes, and there's more beta cell dysfunction as well as insulin resistance and ectopic fat and the low lean muscle mass as well. And the South Asians have a very rapid transition from prediabetes to diabetes, where there isn't that much time for diabetes prevention interventions to work, about 5 years. LP(a) burden is quite high, and CAC burden is high for men especially, but there are many modifiable risk factors, and that's where I'm very optimistic about being able to change the trajectory by more effective implementation of prevention messaging. And we need to leverage social networks for lifestyle change. The risk factors vary dramatically among Asian American groups, and we absolutely have to disaggregate subgroups, and we need more longitudinal data. And I'm really looking forward to this new wonderful NIH, mostly NHLBI funded cohort called the Mosaic study that will be launching this fall. Fred Hutchinson is the coordinating center, and there are 5 sites around the United States that will be recruiting 10,000 Asian American, Native Hawaiian, and Pacific Islanders. And I'm privileged to be in the steering committee chair role for this cohort. And I hope we learn a lot more about each and every different disaggregated Asian American group once we have this study. And with that, I'd like to thank all of our participants and staff and investigators and the funders of Masala. I'm happy to take some questions if we have time.
Well, thank you for such a wonderful talk and so informative about cardiovascular disease and differences in health, especially cardiovascular disease among different Asians. I think it's so important to disaggregate the various Asian American groups, since your data show that they are so different. We don't have a whole lot of time, so so let me highlight some of we have a lot of questions, so that's again show how wonderful your talk have stimulated. Let me ask a question from Frank, who wanted to know, does intrauteral conditions affect the differences that you have described?
That's a great question, Frank. I wish we had any US data on that. We don't. There's some really nicely done studies coming from North India in Pune with, I'm blanking on his name now, but you know who I'm talking about, the investigator from North India who's been looking at this for many, many years. So there, what we know is fetuses or new, infants born to South Asian women, Indian women, are leaner. They look leaner in terms of their body weight compared to European babies. But if you do whole body DEXA or other ways of looking at their fat, there's actually a lot more fat in these smaller babies than compared to the European babies. So there is a lot of emphasis now in looking at that in utero environment, looking at methylation and other changes that may be contributing to the insulin resistance and undernutrition and the birth weight changes in babies. I would love to be able to do some of those studies in the United States as well. GDM rates are definitely the highest in South Asian Americans in the United States compared to other groups too.
Dr. Flo Brown has a question. Since you're recommending GLP agonists, they too cause a lot of weight loss, and some people have suggested they even lose lean body mass. Are there any specific data on Asians or South Asians on GLP agonists and preferential loss of fat versus lean mass?
That's a great question. We're actually, there's a study ongoing that I'm helping with in India that is looking at this, randomizing people with new onset type 2 diabetes to GLP-1 versus SGLT2 versus metformin, and to look at differences in change in BMI as well as in measured muscle mass and fat mass. So the verdict's out. I think we know that loss of muscle mass is a real problem with GLP-1 agonists. We think that there may be less of this problem in the dual and the triple agonists that are now soon to be out on market. And I think we definitely need more data to learn this in South Asian.
I'm going to end with respect to everybody's time and thank you again, Dr. Kanaya, for such a wonderful talk and obviously stimulated so much conversation. So if people have questions, we may forward to you and see if you're willing to answer some of the great questions that you have induced. So thank you again for giving us a great talk, and thank the Wing family for sponsoring this great lectureship for the Asian Americans and health. And thanks everybody for coming to the meeting.
Thank you so much.